All right, again, good afternoon. It's my privilege to welcome you to today's very intriguing lunchtime conversation as a part of the 2024 Richard Payne Lecture in Faith, Justice, and Healthcare. I am Geovanny Martinez, Senior Lecturer and Fellow and the Executive Director for our Center on Law, Race, and Policy. Professor Trina Jones, a Jerome M. Cope Distinguished Professor of Law and Director for the Center of Law, Race, and Policy here at Duke Law, could not join us this afternoon, but she sends each of you her warmest regards. Welcome. I want to acknowledge our friends with the Theology, Medicine, and Culture Initiative at the Duke Divinity School, as well as all of those in partnership to pull off today's afternoon lunchtime talk and lecture this evening. Dr. Patrick Smith, Victoria, Rachel, and team, thank you for all of your work in getting us here today. Next, I want to thank our law school for its support, Dean Carrie Abrams, for its support of this lunchtime conversation this afternoon, and our team working behind the scenes to pull it off. Taylor, Becky, Val, Miguel, Jeff, and team, and everyone else, thank you. I also want to acknowledge the Duke University Office of the Provost for its continued support of our center. Thank you. Next, I will note that our Center on Law, Race, and Policy advances racial equity by empowering the next generation of leaders. Our educational programs, cutting-edge research, and community partnerships foster understanding of the interplay between race, law, policy, and people. This event today furthers our mission. Now with us today, we have our very own H. Timothy Lovelace, Jr., John Hope Franklin Research Scholar and Professor of Law here at Duke Law. Professor Lovelace is a noted legal historian of the Civil Rights Movement whose work continues to examine how the Civil Rights Movement in the United States helped to shape international human rights law. He also is a faculty affiliate of our center, so I consider him a part of the Center on Law, Race, and Policy family. So thank you, Professor Lovelace. And in a second, I will turn it over to Professor Lovelace, who will introduce our distinguished guest this afternoon, Dayna Bowen Matthew, Dean of George Washington University School of Law and the Harold H. Green Professor of Law. Now, not to get ahead, but Dean Matthews' lecture this evening will explore how achieving justice in American health is the imperative of all believers and the key to achieving liberty and justice for all, something we hear often. At this point, I'll just add a little bit of background, right, in terms of the lecture and what the impetus for us being here today. Dr. Richard Payne, Esther Cauliflower Professor Emeritus of Medicine and Divinity, was an internationally esteemed pioneer in pain relief, palliative care, oncology, and neurology. Important, while over the course of his career, Dr. Payne helped to lead a number of prestigious institutions and academic societies, his scholarship and academic leadership never displaced his central commitment to care for people. Therefore, annually, the lecture in his name honors academic, clinical, and lay leaders who, in their work and research, embody the late Dr. Payne's spirit of caring for the whole person. With that, it is a treat to hear from our distinguished guests today. Please give them a warm welcome.
Thank you so much, Professor Martinez. Thank you to all the event planners, and thank you for coming out today. We have here Dr. Dayna Bowen Matthew. She's the Dean and Harold H. Green Professor of Law at the George Washington University Law School. Dean Matthew is a leader in public health and civil rights. She focuses on disparities in health, healthcare, and the social determinants of health. Dean Matthew is also the founder and the inaugural faculty director of George Washington's newly chartered Equity Institute. It's an interdisciplinary hub dedicated to addressing racial, ethnic, and socioeconomic injustice. Dean Matthew is the author of 2 best-selling books, Just Medicine, A Cure for Racial Inequality in American Healthcare, and Just Health, Treating Structural Racism to Heal America, recently released in paperback, I saw.
So now I can afford it.
Yes. Thank you for joining us today. So let's just jump in. Can you begin, the titles of your book talk about justice. Can you just define justice and talk about how you think about justice?
I love the way you jump in on the easy question. What is justice? Can I just thank some people first before I start doing that?
Absolutely.
I feel so honored to be here. The connections between me and Professor Lovelace, which is very hard for me to say because I have known Professor Lovelace and his wonderful wife Daisy since our days at UVA in Colorado. And I'm just so thrilled to see you thriving here and doing such amazing work. Your work has always been inspiring to me. And so it's an honor to be interviewed by somebody I've admired for so long. And then to be here with your amazing Dean Carrie Abrams, who again was with me at UVA. And I kept watching her and going, I want to grow up to be Carrie Abrams. I love her research. And then she went to the provost's office and then she became dean. And I was like, I'm going to do that too. So I don't know what you're doing next, but I'm following in your footsteps. You are doing an amazing job leading this phenomenal law school. So I just want to say thank you for having me.
Absolutely.
What is justice? Okay. So I don't think it's news to anyone who's at Duke Law School that there are many conceptualizations of justice, right? We can think about justice in a libertarian sense, which I do not, right? But it would mean that we are looking for a justice that basically leaves everybody alone, lets people do what they want to do without interference, right? We could think about justice in a utilitarian sense, which is we're looking for the general happiness of the highest number of people that we can do it. When I think about justice, especially with respect to the law and health, I think of it in a Rawlsian sense. So John Rawls' A Theory of Justice really tells us about equality of opportunity. And I leverage that notion of equality of opportunity to connect justice with law, particularly with civil rights law. So as you've heard, I particularly focus on civil rights law, which means my space is the 14th Amendment, and my space is the Equal Protection Clause. And I take that word equal and the aspiration of equality that this country ostensibly stands for. Be careful, Dayna, right? Let me get back out of the controversial space. It's hard not to be there right now, right? But I take that very seriously. So I think of justice as John Rawls did and does, as equality of opportunity, as fairness, right? And I think of health outcomes as a great measure of justice. So there is a health philosopher, his name is Norm Daniels. Does anybody know him? Worth a read, because although he's not a lawyer, his basic premise for all his writings is that health is a byproduct of justice, right? You can tell how healthy, how just a society is by its health outcomes. And I specialize in health disparities because that is an indicator of how disparate the access to justice is in America.
Yeah. So in your comments, you were moving us towards thinking about more than individual healthy behaviors as a framework for thinking about justice. Yeah. There's a structural component here to your understanding of justice. How do structural inequalities, let's say in areas like housing or criminal justice or education or employment, contribute to disparities in health outcomes and probably just a reduced life expectancy for those in...
Thank you for going there. That's the whole ball game, right? The connection between justice and health is that there's such vast injustice in all of the social drivers of health that they themselves produce the disparities in health outcomes, right? So when we look at the fact that between where we're located now and 7 miles from here, right, the life expectancy difference can be as much as 20 years, right? And that's because 7 miles from here, people breathe a different quality of air. They drink a different quality of water. They have access to a different quality of food. Their stability in housing is different. Their educational access is different. Those are all the social drivers of health, right? And so there should be no surprise that their levels of asthma, their death rates from the leading causes of death are different. Why? Because Health is determined maybe 10% by your biology, maybe 10%. The best estimates are even access to clinical health, 10%. Social drivers, 30, 40% of the determining driver for what produces your health, right? So if I have inequitable access to all of those social drivers, housing, food, air, water, all of the things that drive my health, then that's going to produce the inequality that we're measuring. Now, let me say this. The reason law is so important is because every one of those social drivers is organized and distributed by law. So we have the ability to dismantle the inequality that law created that produces inequitable health outcomes.
There are social costs, people dying early. There are also economic costs to health injustice. How do disparities in health drive up economic costs? Are there potentials here to save American healthcare by addressing health disparities?
So there are a lot of ways. I'll go to the most controversial first. Let me do the easiest one first. We estimate, Tom Leviste is the researcher that's done the best work on this. He's at Tulane Medical School, School of Public Health, excuse me. And we estimate that about 84,000 people die prematurely and unnecessarily a year due to health disparities. So those premature preventable deaths are about 84,000 people. That's lost income, lost productivity, lost lives, right? So that's the easy way to look at it. I like to more controversially provoke people to realize that health disparities cost everyone. I don't think we have long enough for me to take a long, polite amount of, sort of North Carolina polite amount of time to get to the word racism, so I'm just gonna have to get there right now. I want to identify racial discrimination, racial disparities as one of those social drivers of health, right? One of those social drivers of health disparity. And the reason I do so in response to your question about costs is because racial discrimination costs all lives, right? Not Black lives, not white lives, Asian lives, all lives, right? And we have some pretty definitive data about this. One of the ways we know, for example, is that we can scrape Twitter data or Google data by geographic area and searching for words that are racially charged, right? So we can search for the N word and look at the concentration of the number of searches or uses of those words in a particular geographic area. We can search for phrases like all lives matter or worse in a geographic area. And then we can cross-tabulate those with death rates due to myocardial infarction or life expectancy or premature infant mortality, and those rates correlate positively with racist searches for Blacks and for whites. Not at the same rate, right? So we can say racism is a bad thing for everybody's health, right? It costs your life, costs your income, costs your health. And so we can measure lost quality of life, lost number of lives, and we can actually economically measure the cost of those lost wages. Don't have those numbers at the tip of my fingers, but there's something like $200 and change million per year that we lose in income because of premature death.
Yeah. I'm just kind of circling back a little bit. You mentioned the Equal Protection Clause. Let's talk just for a moment about the possibilities of law in addressing health outcomes. In some of your work, you talked about the limitations of current anti-discrimination law to address health disparities. Just elaborate on that just a bit about the limitations of law and civil rights law. We often think about civil rights laws having lots of possibilities. What are the limitations of anti-discrimination law to address the kinds of problems that you've identified?
If you accept my premise that the social drivers of the social drivers of health are the most important determinants of health outcomes and disparities. If you accept that premise, and then if secondly, you accept the premise that follows, that to the extent that there's inequality in distribution of housing, educational attainment, clean air, clean water, food access, and so forth, then the promise, first, of the Declaration of Independence that all men, let's just say all, are created equal and entitled to a set of rights, regardless of who they are, gives us a link, if you will, to the way that the Equal Protection Clause or enforcing anti-discrimination law might help to rectify those inequalities, right? So we might look, for example, at the Equal Protection Clause's enablement of the Title VI language, which is beautiful. It's beautiful language in terms of a federal statute that reflects our aspiration that no one who receives federal funding or the benefits of federal funding should be allowed to discriminate on race, color, or national origin grounds. Sounds wonderful. It's a great and powerful piece of law. Even more importantly, when the Affordable Care Act was passed, Section 1557 of the Affordable Care Act basically enveloped and embraced Title VI, as well as the Americans with Disabilities Act, Title IX, and all of our anti-discrimination law. And so here we have this extremely powerful, positive source of law, basis of law, that in my view has been neutralized by its interpretation and application by our Supreme Court. So starting first with Alexander v. Sandoval. Okay, Alexander v. Sandoval, it was decided, somebody check me as you're looking, 2001, where the question of whether we can, in Title VI, still bring private causes of action that allege disparate impact in a activity that is funded federally was answered in the negative, right? So essentially, Alexander v. Sandoval gets rid of a private cause of action to enforce Title VI's grandiose, excellent anti-discrimination language. And so we're down now to only administration and enforcement of one of the most powerful civil rights statutes that would have affected health. Why? Because Title VI is a wonderful way to say to hospitals, you have to have interpreters for people with limited English proficiency. Because you spend Medicare dollars, you cannot spend them in a discriminatory fashion. But we can no longer do that as a private cause of action. Title VI is a fabulous way to say the disparate impact, were we still allowed to do that with a private cause of action, of any cause of any medical treatment that, whether you intend or do not intend to discriminate in a way that makes your outcomes disparate, your access to ancillary services like MRI, or even, my husband's a cardiac surgeon, even access to cardiac surgery is disparate by race, by ethnicity, even by gender. And Title VI would have been a wonderful way to do that justice, if you will. It's been neutralized because it's not only unavailable as a private cause of action, right? But it is underfunded as an administrative cause of action. I don't know if you've been paying attention, but the administrative state is being dismantled as we speak as well. So these laws, though they sound aspirationally attractive and have worked, that's the thing that I think is really sad. When you look at the history of Title VI litigation, of 1557 litigation, up to about 1989, 90, the sad thing is it was working. It was working to desegregate hospitals. It was working to equalize access to health insurance. It was working to make sure access to ancillary or exceptional services were available. It was working to desegregate nursing homes. There's a long list of ways in which healthcare was made more equitable, more just when that law was in effect than it is now.
Yeah. You mentioned equal protection in Title VI. My mind goes to Students for Fair Admissions v. Harvard, right? As you know, Harvard and UNC's admissions policies were challenged, and the case went to the Supreme Court. In 2023, the case was decided. The court declared that these admissions policies, which considered race as one of many factors in admissions, violated the Equal Protection Clause, and then because the Equal Protection Clause is coextensive with Title VI, violated Title VI, then putting Harvard on the hook. In that opinion, what was so striking to me in the context of this conversation was Justice Jackson's opinion. Justice Jackson, in her dissent, talks about the place of students for fair admission, its stakes for the medical profession. So not simply admission, let's say, to medical schools, but also the impact on the profession. Can you talk about your impressions around Justice Jackson's opinion and her analysis?
Yeah, they're joyous.
Okay.
Justice Jackson did something that I try to get my students to do, both when I teach public health students, medical students, and law students. And she did something that's actually relatively new, is sort of a theoretical frame in health and healthcare. She was a legal epidemiologist. Now, I don't know if this term is familiar to you or not, but she basically said, let me explain to you how the law impacts all of the health outcomes that are relevant to changing affirmative action as an access to education, as a legal access to education tool. So she starts out, as any good jurist should, explaining all of the progeny of laws that followed the ratification of the 14th Amendment. So she goes through the Black codes and how the laws were used to make sure that Black labor was circumscribed. She goes through those historic misuses and discrimination and brings them current to tax laws today. She brings them current to the laws, in her opinion, her dissenting opinion, in SFFA versus Harvard and UNC, brings them current to the way that laws change access to the economic drivers of health, right? And then she ends by citing disparate outcomes in health itself, the number of times more likely you will die from heart disease. Your child will have elevated blood levels that will inform their ability to learn and to prosper educationally. She looks at medical data as an outcome of the disparities that will result and have resulted from inequality in the law. It's connecting epidemiological data on health outcomes to legal drivers that say very plainly in this opinion, what we do in law matters not just to lives, but to life itself, right? She says, when you say that I cannot have equal access to educational attainment, you are also telling me I am going to live sicker and die quicker than other populations. It was amazing.
Wow. We've been talking about law's limitations. Let's talk about law's possibilities. Are there just a couple of very specific, let's say, legal reforms or policy initiatives that might change the direction in the fight for health equity?
Yeah, I used to have a list of those things, and then last week happened.
Oh my goodness.
And so we got to change the list. But let me just say, I don't want to be Debbie Downer, right? I don't have the ability to be in despair. I think there's something about me, and maybe it's my age, maybe it's the fact that my mother was born in North Carolina, that I feel a sense of fight rather than a sense of defeat. And so, yeah, I'm glad that we're going to end on a note that says what can be done. All politics is local. That's never been more true than it is right now. One of the things that I am ecstatic about, the privilege to give the Richard C. Payne lecture tonight, is because I'm going to be able to take a look at local data here in Durham and look at the things that law can fix here, right? There are plenty of inequities right around this building that can be touched by law, and more importantly, by law students, right? There is nothing unique about Duke. There's a pattern that I've noticed, you've probably noticed it too. Large, Prestigious, successful R1 research universities are usually located amidst vast poverty and inequality right outside the door, right? So if you want to have an effect on housing, either enroll in or advocate for a housing equity clinic. In your interests about education and educational attainment, if you have some spare time, I know that pro bono work is very important to your dean and your school. Do it in the Durham public school system. Do it at an individual and a structural level, right? And you, as law students and ultimately as lawyers, one of the privileges that we have of training you is that we're training an army of change makers, right? We get an opportunity to walk with you as you prepare yourself to go out in the world and do some good and make it better. So the law is useful, for example, in local school districts in making clear who gets access to food, who gets access to college preparatory courses, who gets access to something as simple as transportation, right? An anecdote, and I'll grant you it's just an anecdote. My daughter was trained here at Duke in the Pratt School of Engineering. And wherever she goes, she teaches a coding course for public school students. And she teaches it from 6 to 7:30 in the morning, right? And what she has noticed is that the students who need it the least are the ones who are able to come because their parents don't need to get childcare so that they can go and work as janitors, as healthcare workers, as CNA. And so she went to the school board and she asked them to make the bus route earlier and make breakfast earlier so that she could get the Latino population that's in her neighborhood into the class for coding, right? So this is 6th, 7th, and 8th graders who now get 6 to 7:30 a.m. breakfast and coding so that their educational outcomes can be different. You can do that now, right? And you can make those differences even if you can't enforce Title VI to make sure that school funding is equitable, right? So I would look for ways, and they're all around you, to touch the issue that is passionately touching you, right? If it's housing, look at the eviction rates and ask yourself, what is the racial and economic skew of eviction rates around your community, wherever you end up, right? If it's food access, ask yourself what the zoning laws are that permit food swamps and food deserts to exist where they do in your neighborhood. So my view is that there's plenty of inequality to go around, and the people who made it possible for us to sit here are depending on us carrying on because they did so in much worse circumstances than we face today.
Absolutely, and that's a very hopeful note. Let's open it up. This is a student conversation. We want your questions. I'll just call on you, and if you could just provide a question. Yeah.
Hi. First, thank you for being here. That was a really interesting conversation. My question pertains to, you mentioned the more explicit ways that racism kind of feeds into health disparities in certain geographic areas, but I think we all know that a lot of the issues that occur are after the fact, after we receive care, with the implicit biases that many healthcare providers have. How do you suggest we address those issues, specifically in a time like this where the federal government is going to seemingly jump in and try and attack anything that addresses diversity or equity, particularly as many of the societal issues that are at hand, creating those health disparities, are going to take time to fix? How do we fix it today, those implicit biases?
Yeah, we have to shape shift a little bit, right? Because the thousands upon thousands, hundreds of thousands of dollars that were invested in anti-bias training for health providers for a number of reasons, and I'm happy to go into them if they're of interest to you, but for a number of reasons, those dollars are drying up and they're going to dry up, right? There are those of us, you might not like this answer, there are those of us that are only partly distraught about that because the data is not altogether clear that those dollars really made the difference, other than making people feel better, that they were intended to make. So what really does change bias? What really does change the fact that if you're my doctor and I'm your patient and we don't look anything like each other, you come into the room having some background assumptions about me that will color your treatment, your communication, your prescriptions, even the way that you read your data, my data, right? You're gonna do that because of the biases that our society puts in your environment, right? It's everything about the way we breathe. It is very important to realize that the only thing that really changes bias on a long term is a sustained contact with counterfactuals, right? Sustained contact with counterfactuals. So just like the feeding of the background data that tells you, my doctor, that I, your patient, am a criminal, I have non-compliance, I probably don't have the resources and therefore you're gonna treat me different. That's constant, right? That's the music you listen to, that's the newspapers you read, that's the church you go to, right? So too do the counterfactuals have to be constant, right? So all the more important that we change the distribution of diversity in the medical workforce, not just at the receptionist level, right? It is all the more important for Duke, for George Washington, to admit and train diverse populations for the medical workforce at all levels. It is all the more important that we have sustained conversations about how I own and account for my disparities, my biases. Going into the room, I have to talk about it all the time because it's being reinforced all the time. And it is only the case that when we have professors, deans, people who are allies, whether of color or not, who know the importance and are constantly and vigilantly making sure it's part of the curriculum and making sure it's part of our hiring and promotion, that we're really going to change biases, especially in this environment.
Great. In the back.
Thank you, Dayna Bowen, Matthew. Dr. Kamara-Jones says that one of the biggest barriers to addressing health disparities is the United States societal pushback against being historical. So we have an ahistorical nature about us, and I really appreciated your breakdown of Justice Jackson's use of history and following the line through epidemiology. So my question for you is, how can we become more historical as a healthcare society? So folks going into the healthcare profession, how can we continue to put history in front of us to know where we were, to know where we're going next?
Yeah, it's a great question because the healthcare history is one that ultimately ends up being pretty inspirational when you talk about disparities. I mean, healthcare institutions were among the most segregated institutions in our nation's history. I was born at a time, I'm not gonna tell you how old I am, but I was born at a time that if I had been born in Charlottesville, Virginia, where I worked, where I met Dean Abrams, I would have been born in the Negro ward. I use that because that's the name that they gave it, not because I like the term, right? Which was right next to the veterinary ward in the basement of the hospital, right? So I say that to say, I don't care how old you think I am, I'm not that old, right? So it wasn't long enough ago that that was true, right? That said, right, I may include it now because of your excellent question. Those scenes that desegregated schools, right, where people turned fire hoses on one another and dogs on one another, they were not necessary to desegregate hospitals. And the reason was because physicians, dentists, and patients sued hospitals in order to get Title VI enforced, right? At the time, it wasn't Title VI, but Title VI ultimately was passed. And it was because physicians, healthcare providers saw civil rights as part of their healthcare mandate, right? They didn't think that their job, historically, was just to treat diabetes, right? I hope I can quote Dr. Payne accurately, because he says something like this: we're not supposed to just treat diseases, we're supposed to treat people as whole people. That's the history I'd like to put before people as I'm here, having the opportunity to speak to you, to speak to the people at the Divinity School, the medical school. The history of physicians, of clinicians, of healthcare providers realizing that their responsibility is not to a disease, it's to a society. And their patients will be no more healthy than they are exposed to justice, right? And that's why I love the opportunity for medical students and law students, right? Legal practitioners and public health practitioners to work together, right? To solve the problems that historically have been solved by that united advocacy.
Can I take the moderator's prerogative? Can you talk a bit more about that? I think about the civil rights movement, right? In Mississippi, there are medical students, there are doctors who are coming to Mississippi to treat people during Freedom Summer. Can you talk more about just that history and the richness of that history?
Yeah, it's so incredibly rich. If you're familiar with the case Moses H. Cone Hospital versus Simpkins, right? It is actually how we got Title VI in the first place, right? Because, as I said, 2 physicians, 3 dentists didn't have admitting privileges to segregated hospitals in, it's actually Greensboro, North Carolina.
Greensboro, North Carolina.
It was Greensboro, North Carolina, right? They sued, and they said, this is not fair, right? Now, after that case was passed, and if you know the legislative history, it was going up to the Supreme Court, and the legislature, Congress, different Congress, 115th Congress said, boy, we're going to see a lot of these cases over and over again if we don't pass Title VI. So Title VI really is a direct result of advocacy by the medical profession, right? But even after Title VI, as you know, it's not self-actuating. People don't go, especially not in Greensboro, North Carolina, oh, the law has changed, well, we better change. That's not how it goes, right? So people had to, by the dozens, go knock on doors, investigate, do these investigations of hospitals, report to the Health and Human Services Department that segregation was persisting, and do the kind of legwork, the kind of groundwork that makes the law actually the same on the streets as it is in the books. It doesn't happen without the hard work of people who care really after the law is passed to enforce and implement that law, right? So much of that came from the medical profession, right? The Medical Committee on Civil Rights, and I do this a lot of times. I say, I don't know what your appetite is for advocacy. It could be that I'm going to change your research questions. So you're going to go to the lab and you're going to make better research. Thank you, I need that too. Or it could be that I'm going to get you to go to Washington, D.C. Now that I live in Washington, D.C., I'm all wrapped in the flag and I'm about America is access. You can come on down and talk to your senator, and you really can, right? And maybe that's your contribution. But when you look at old pictures of the marches that preceded Title VI and the Civil Rights Act of 1965, even the Fair Housing Act, the Medical Committee for Civil Rights always had a banner and always had blocks and blocks and blocks of people marching with them, right? I contend that lawyers can't do it alone. We can't do it alone. In fact, the legal solutions, that's the low-hanging fruit now. It's so much more complicated than that. We started off talking about justice and equality.
Yes.
Yeah, if you think there's a simple definition of justice, we've muckied that up so badly now. Equal, oh God, what does it really mean? Do we mean social equality? No, we really don't. Do we mean contractual equality? We can't do it alone because we get inside our heads and we don't realize how it really affects people on the ground. Health is one of the best measures of how it affects. Not to have equality, not to have justice, and pairing ourselves with people who can do that measurement, who can quantify the extent and impact of our confusion about what the word equality means, is so helpful and so impactful. I don't even know what question I was answering, but I'm really into it now.
Yes. Other questions? Yes.
So, my mom's an OB here in North Carolina, an area with these sort of massive health disparities in deliveries of children. And she's been engaged in this project of racial uplift, but really sort of feels hopeless. And what she says essentially is like, insurance companies are the root of all this evil. And I'm wondering if you would agree with that assessment, and then what levers really exist for the law to pull on those companies?
So I have a tremendous amount of respect for your mom. She's in a place where the disparity data is particularly discouraging, right? Maternal mortality disparities between Black and white women at every income level, which tells us it's a race problem, not just an income problem, are really discouraging. And so when I say I slightly disagree with your mother, it's with the utmost of respect. Insurance companies can't be the root of all evil. Hurry up and ask me
What would the
another question.
divinity school say about this?
Right, anytime we identify one thing, it's so easy to identify one thing as the source of the problem. It just makes it so easy when your enemy is just one thing, right? Especially something so big as the insurance company. Now, I will say payment systems are really troublesome. They are a real core issue that require reform. So if you are not a litigator, you're not an activist that's going to go march, and you are not going to petition the government for anything, but you are keenly aware of contractual inequality, and you want to attack payment systems, which are a very, very big driver of healthcare access in the United States. That's another ground game that really needs a lot of attention, right? When you look at uninsured populations, again, right here in Durham County, is that what we're in? Durham County, right? So there's Duke, the campus, right? And then right around you, there are places where it's still 18, 19, 20% uninsured populations, right? That's no access to healthcare whatsoever until you get to an emergency room, right? And that's what your mother is feeling when she gets a problem at that level. First of all, it's too late, it's too expensive, and insurance companies won't pay for the kind of care that she would aggressively have to put in play in order to try and equalize what is basically systemic inequality, right? I don't get prenatal health care because I can't pay for it, and I can't get off from work, right? And I have no child care, and I have no transportation. So it can't just be the insurance company. It has to be all of the interconnected problems. That's discouraging if you're the only person working on them. But hear me, this is one of the things that I think law is particularly good at, particularly well situated to do. We as lawyers are particularly well situated to build coalitions, right? To collaborate in problem solving that would be too much for a physician community, right? Because think about your physician friends. Like my husband's a physician, and this has been him since the 8th grade, right? Right? But we have a different understanding of what it means to pull different resources together in order to problem solve. And that's the beauty of a legal education. We build incredible problem solving coalitions. And that's what's needed to give your mother, I think, a larger view of the problem that she's solving, and then also to give us the privilege of being able to chart our progress, to track what's happening. Something as simple as, and I'm going to go off topic just for a second, but something as simple as watching to make sure that the incoming administration doesn't stop data collection, right? Because you can't fix what you can't count, and they know that, right? The first thing that happened, I worked at EPA, and the first thing that happened when the EPA leadership changed was in order to stop collecting and dissecting data stratified by race and by ethnicity. So higher education will play an increasingly important role in making sure that we keep the data collection available to solve the problems that cannot be hidden if we're vigilant about that. So that's my pitch on that. Was there a question?
That's great. There's another question right here. Yes.
Thank you so much. I think on this sort of note of insurance, I think one of the most sort of expansive and creative ways that states can start to really take control of their healthcare is through Medicaid expansion. I think it creates just a tremendous difference in what states can do and also who states can cover. I'm from Louisiana, which I know North Carolina is now an expansion state, but Louisiana for a long time was the only Deep South expansion state. So there was a lot of sort of experimental potential there. And so for all these other Deep South states that may not have a path to Medicaid expansion right now because of whatever sort of political factors motivating that, what do you see as like a path for them to channel those ideas or to even expand Medicaid in the future?
So what's interesting is that Medicaid expansion has happened in some unusual places because it is so economically available. Now, I'm not a politician, so I'm not going to really be able to be super insightful about this, but one thing I do know, as an African-American woman, I code shift. And we could code shift Medicaid expansion so that it becomes advantageous for Deep South states that under other circumstances and administrations wouldn't do it, right? So you can keep your eye, if you're looking at Medicaid expansion specifically, I'm not saying this is a strategy for every problem, right? But if you're looking at Medicaid expansion, you could keep your eye on the ball of increasing access to healthcare, right? And when I go into a Deep South state that doesn't like the term Medicaid expansion under the Affordable Care Act and doesn't like the term social justice and doesn't like that term, I can speak of it in other terms if I keep my eye on the ball of access to healthcare, right? If I keep my eye on the ball that gives us really good data correlations between the reduced cost of delivering healthcare and the increased access to Medicaid coverage, right? If I begin to touch the budgetary interests of Deep South states that they want to stop spending, 20% of their budgets on healthcare delivery, and they can do it if they are willing to expand Medicare or access to Medicaid coverage in spite of the fact that the source of it is social justice. So here's something that I thought was pretty amusing. From my bio, you know I lived in Kentucky for quite a while. And one of the things I was doing when I was doing my qualitative research for Just Medicine was interviewing people on their experiences with disparities and bias. And person after person after person would say to me, I don't remember what the name of it was, but let's say Kentucky's Medicaid was called Care Aid. I don't know what it was really called, but let's call it Care Aid. And I would interview people and I would say, so how do you get your health care? And they'd say, I get it from Care Aid. And I'd say, oh, so you have Medicaid. Oh no, I do not have Medicaid. Medicaid is free, I have Care Aid. And so, okay then, you have Care Aid, right? So if we can get you to understand that health insurance is directly related to reducing the cost of health care and increasing the access to health care, then we can call it whatever we want to call it.
Yeah, right here.
So I was really interested by your discussion of the social determinants of health, and I feel optimistic thinking about that is an area where we might be able to make some change. But it does raise a question in my mind about value, and I think typically, like we as a society tend to measure value in a way that's relational. And I think a lot of those determinants that you mentioned, like to try to change those would force us to confront that idea of relational value. For instance, you mentioned this university being placed in areas that are poor and that sort of trend. But that's because we extract from those communities and it creates the value here for this to be valuable. So how do you believe that we can kind of conquer that sort of mentality change that will be required to make a real change in that area?
Yeah, your question is packed, and I'd love to have like an hour-long discussion about that. There comes a point where my optimism has to be informed by a fundamental belief that there are good people with good principles in higher education, right? That believe, as I do, that higher education is uniquely positioned to build the kind of relationships that you're describing because we're committed to bringing people of disparate backgrounds and viewpoints into relationship with one another so that contact theory can work, right? So that we can sit in front of the classroom for 3 years in a row and you can, no matter where you come from, walk away saying, what they told me on the farm back in name a state can't be true because I met Professor Lovelace or I worked with Dean Matthew. And higher education is the one place, I think, in our society that hasn't failed yet and won't under our watch, hasn't failed to build the kind of relationships that yield social mobility, that yield contact, and that yield the hope that we can, in principle, live out our calling. Really, I think of it as calling. Our calling and our purpose, right? To change society by solving some of its biggest problems, either because we teach people or we build new knowledge, right? So the relationship of Duke to Durham, or Harvard to Cambridge, and Columbia to Harlem, every one of the schools that you think of, Brown to Providence, Yale to New Haven, GW to Washington, D.C., one of the most inequitable communities in the nation, right? The relationship has to ultimately change if people like me, people like Dean Abrams, are leading those institutions in ways that are different from the way that they have historically been led, so that we feel a responsibility to reverse the extraction, right? We have to feel an obligation in principle, in our values, in our gut, right? To say that the only reason I have the tax breaks, the population of health patients on whom I can practice, and I do mean practice, right? The real estate ownership, the only reason I have that is because institutionally and historically, I have created and benefited from this inequality, right? It is time to reverse it. That's why I'm a dean, honestly. That's why I get up in the morning. I remember when I was in the interview, I was asking myself, I don't know if you had this feeling, I was like, why in the world am I doing this? I have the best job in the world. Legal academe, if you haven't considered it, it is the career. I can write my articles from the Amalfi Coast. It's lovely. So why did I interview for that position? I interviewed for that position because I thought I had a platform to change the history for a little bit of time of GW's relationship to Washington, D.C. Right? Go ahead.
Okay, so that's a larger sense, but then what about on the smaller sense? Because the same idea happens with housing and environmental issues. You know, NIMBYism and the idea that some communities, we create waste has to go somewhere. The fact that our community is not the one that's closest to the waste is the reason that our community is valuable. So how do you get that sort of change on a smaller level as well?
Yeah, I think you pick the problem that speaks to you and you work on it. So the answer is different for, let's say, housing, right, or pollution. I'm going to take pollution because that's an easy one in North Carolina. You guys have these CAFOs, is that what you call them? CAFOs, which are amazing machines of health inequality, where people take agricultural waste, they mix it with water and spray it across minority communities, right? Atomize it across minority communities. Let's say housing is my issue and it's on a local level, on an individual level. That's where your activity starts. Now, I think one of the secrets is you don't call yourself responsible for the entirety of housing problems, right? You say, I am concerned deeply about housing inequality, racial segregation, agricultural waste that is deeply affecting the quality of life, the value of property, the educational attainment in North Carolina. And I'm going to attack that. I'm going to go to the legislature and I'm going to limit the amount of pollution that is allowed to be spread over these neighborhoods. I am going to find monitors for them. I am going to go to the EPA, the local EPA, and I'm going to work on reparations for housing neighborhoods. I'm going to do what it takes to solve that problem, right? You're here at Duke to learn what tools you have available for the questions that you're passionate about. And if you get passionate at a relational level about housing, you now have the tools to do something about them on a local level. the caution I have for you is, and maybe this is my age speaking, there's a way in which despair comes if you think you have to change everything. But just a sense of real purpose that drives you to change something that you're passionate about. As a lawyer, I think there's no better posture and no better place from which to leverage what you have now as power and privilege to do the things in the area that you care most about.
Great. Purpose. Right. Purpose. What's our calling? This is a great way to end the conversation. Thank you so much, Dean Matthew. Let's give a round of applause.
So, I mean, I'm touched, I'm tickled, and you know, like that's the best way to describe it. So, we thank Dean Matthew and Professor Lovelace for such a remarkable conversation this afternoon. Please accept a small token of our appreciation. You know, and you know, we are in the South, so I have to, you know, engage in our Southern hospitality. You know, but as was said, we can carry this conversation on. And as we wrap up, the one thing that comes to mind is Charles Hamilton Houston, particularly with that charge that is, you know, a lawyer is either a social engineer or a parasite on society. So, you know, look it up, think about, you know, that, and think about where you can have impact and what you can do in your respective advocacy. That's suffice it to say, thank you. Thank you so much. Folks, if you're registered for this evening's, it is a sold out lecture, but we look forward to seeing you there. And thanks to each of you for joining this afternoon and for being a part of this conversation. And I'll say that CLRP, the Center on Law, Race, and Policy, will continue to explore topics and matters with cutting-edge implications. So please stay tuned for more. But again, thank you so much, and enjoy the rest of your day.